we've now got two GPs to talk to us about some of the critical relationships for CCGs. We've got Johnny Marshall, who's a GP and who is Director of Policy for the NHS Confederation. And we've got Minesh Patel, who's a GP and Chair of Horsham and Mid-Sussex CCG.
Good afternoon. For those of you who were in here earlier, it felt a bit like we were in Tracy Island with our aeroplane flying over. So if it does fly over again, I'll just keep talking and I'll try and talk more loudly. So Minesh and I are going to quickly run through successes around relationships, I guess, within the commissioning system. I'm going to do just a little bit of a headline level around practices and whiz through that bit. So Minesh will pick that up. And then I'll try and focus a bit more on the relationship with NHS England, if that's okay with you. Now, if you remember nothing else, I think this is all about system leadership, relationships, and behaviours. It's not about constitutions, it's not about accountability frameworks, it's not about contracts, it's all about these things. These are the things that clinical commissioning brings to the agenda that we finally have the opportunity to get right. The challenges, you'll be familiar with those. The solutions, well, hopefully you're familiar with those. The World Economic Forum recently wrote a report on healthcare in the developed world. Why is the World Economic Forum interested? Well, the credit agencies are looking at developed countries' plans for how they're going to manage the demands in healthcare, because if they're not very good, they're going to increase or decrease the credit rating and increase the amount it costs us to borrow money. So this is really, really important stuff. And they really highlighted three key areas that they'll be looking for developed countries to be improving on. One is big data, how we use data to support people's lifestyle choices, their healthcare choices, the planning of healthcare, how we create sustainable communities. We talk about moving work out of the acute sector into the communities where we haven't necessarily created the sustainable communities to keep people healthy, and how we develop new care models. These are the solutions. And none of those solutions you can deliver on your own. They need to be delivered across the system with a new NHS that looks a bit like this. That interdependence of health and wealth health and welfare at a local level. How we bring about a more distributive leadership in the new system that's designed not really to have someone in charge at a national level, but actually to drive that distributive leadership, the engagement at a local level and coming up with local problems for those population health needs that you've identified. And the heroic leadership that perhaps we've had in the past, a bit like some sort of grotesque medieval torture where the patient has had each limb tied to this strapping steed, everyone pulling as strong as they possibly can, but in completely opposite directions. Means somehow we need to create the right sense of system leadership if we're really going to be successful, not just in achieving the relationships, but successful in turning those relationships into meeting the challenges and coming up with the solutions. And unless what we come up with actually fundamentally impacts that interaction between an empowered patient, carer, family, and proactive, prepared professionals and practice teams, we achieve nothing. And it's really important that clinical commissioners don't lose sight of what really, really makes a difference. The practices are the CCG, and the CCG is the practices. That's how they were established. That sense of membership is really, really important. I'll skip over this bit, and Minesh may well pick them up, but one thing I would like to pick up is the sense of the history of practice and commissioning. The advocacy that we have as an individual patient sat in front of us during a consultation is great, but it's limited, because the solutions don't lie within the consulting room. Even people with a long-term condition spend just a few hours in the consulting room and many, many days and weeks and months at home managing their own healthcare. We have to understand that the advocacy that we have in the consulting room, we need to apply that to the wider healthcare system, the social care system, to empowering people as individuals to look after their own conditions. That's the real challenge. That's the challenge around relationships. So what about the relationship between CCGs and NHS England? Well, ostensibly, we have a common purpose. We're all designed to improve the population, the health of the population, to deliver the best outcomes we can from the resources that are available. We've got this sort of CCG commissioning sandwich, haven't we? Where NHS England is responsible for specialised commissioning, it's responsible for primary care, and yet in the middle, we then have community, district general type hospital services. And currently, I think this is the biggest weakness in the whole system. The relationship around that co-commissioning role I think, is poorly developed, and poorly developed even in comparison to some health and wellbeing boards that are starting to create good co-commissioning between local authorities and also with CCGs. And somehow we need to understand how we not only deliver the support role from NHS England, not only that sense of holding to account, which do seem to be quite well demarcated. There's great CCG development framework stuff going on to support CCGs. There are clear accountability frameworks. But that bit about actually putting the system together in a way that meets the challenges that I've described through the solutions that we all know need to be put in place is my biggest fear. And somehow we need to get beyond a sort of a commissioning assembly, which, having never been there, perhaps I shouldn't really be talking about. I think you have to be a clinical lead, don't you, to go to the commissioning assembly. How we move beyond the sort of commissioning assembly in terms of a way of bringing people together so the NHS England can meet CCGs, to actually how we bring NHS England and CCGs together as the commissioning assembly to co-produce, to co-commission new solutions, new ways of improving the way we commission to support the way we deliver healthcare. I think that's the real challenge in the system in that relationships. And NHS Clinical Commissioners recognises that what will sit behind there will be the behaviours that NHS England and the CCGs both provide. So we are planning to do a 360 review. So those of you in CCGs, come in the autumn, you'll be asked to fill out a questionnaire about the behaviours of NHS England, either locally or nationally. And what we're seeking to do is to describe what they should be by the end of June, to give everyone a chance to understand them and demonstrate them, and then to check how the system's doing. And remember one thing. Whenever you set up a set of behaviours that you expect from one side of the partnership, they rightly will expect the same set of behaviours for you. So as we're carrying out that review of how that part of the partnership is working, it's really important we also look at what we're doing to make sure we're up to the job too. So it's all about system leadership, relationships, and behaviours. Thank you.
Thank you, everybody. And I know we're running a little bit late, so I shall zip through my 10 blobby slides very rapidly. But I really want to focus on the relationship with... Oops. If I can get this right. Let's see, where are we? No. Green? Sorry? There we go. Good start for me, and amply demonstrates my IT skills, I have to say. Not getting my slides up. Any technical help here? No? So I haven't been in the bright lights since I was the witch doctor in Romeo and Juliet back in fifth form, so apologies. Were you Romeo or Juliet? I did have a job. No, that's not right. No. Okay, well, perhaps I'll just get going because I know the session's under a degree of time pressure. And I have to say, I don't think we've necessarily in Horsham and Mid-Sussex, there we go, got our relationships right yet. And of course, they take a degree of time to mature. But I think we have a window to mature the relationships with our member practices before we get into a little bit of a stale situation and a degree of stalemate. So there is a degree of being wanting to get on and form these relationships as well as possible. Here, another demonstration as to why I shouldn't be allowed on a podium. So we have to remember that our GP practices and our GPs are actually mini commissioners, and that 90% of all sort of cost decisions, or if you like, the 90% of consultations occur out in the community, and of course that's where a lot of our cost decisions are made. So we really do have to take our member practices really, really seriously. And it is actually where real serious decision making takes place within our communities. And I think CCGs have to really acknowledge that we do share fate with our practices and vice versa. And it's a real journey for us to travel. So looking at the insights and relationships, and Johnny mentioned advocacy, and I think it's really important that we actually build in the advocacy, the insight of our GPs and our practice, the wider members of our practice into our plans. They provide us with a great deal of soft intelligence and other insights from their years of experience around how services could be better, how performance could be improved. But there is a stepping up, isn't there, to be had around population health. So coming back to Johnny's point about looking after the individual in the consulting room, but actually then thinking, how do I look after 2,000 individuals? And is there a different way of doing this? And having to create a lot of new relationships that perhaps don't already exist in your system. So practice may need to develop a very strong relationship with its town council, with its local voluntary organisations, and of course that needs to be replicated at all levels within the commissioning system. I think we all struggle, and I know we have struggled in our neck of the woods in GPs becoming leaders. So it's really important that as our practice leaders develop their skills, that they're actually managerially supported, and it is genuinely a partnership. And I know that sounds a little bit trite, but I know that in a number of organisations, the pendulum swings around how the structures work and who's in charge. And it's really important to try and bed down a genuine partnership relationship between our GP leads who represent practices and the management support within our CCGs. And of course, that relationship building has to extend much more broadly to the public. So we have patient participation groups across the country, don't we, with most of our practices, but actually not all. And we have to consider how we're going to engage with those communities that we represent at practice level and develop those structures where they don't exist. And of course, with the wider healthcare professionals, and I'm constantly struck by the number of specialists and therapists and nurses who actually feel quite shut out of clinical commissioning because we haven't made the time to go and have conversations with them. So our membership needs to broaden in terms of its thinking. So I take a particular view, if you like, that there are some clear aligned goals between member practices and a CCG, and there are some clearly unaligned goals. And an example that I will pick will be primary care and primary care development, and we'll come on to that in a minute. But it's really important that actually if we're going to be clear with our practices as to what we're trying to achieve, that has to be clarified very, very quickly in our commissioning cycle, and then we have to really get to a level of detail around those goals and make sure that we are planning for them. Equally distracting can be the unaligned goals. And later this year we're all having to, or we are going through, enhanced service reviews. And I think it's really important that we have to get the messages correct around exactly what that means and how it'll affect general practice, and ensure that the processes that we use are absolutely right. We all have colourful characters that exist in our systems, and it's really important that we don't avoid them, that we actually make really good use of those characters, because they will challenge us. They are there to scrutinise, if you like, what we're all doing collectively. And if we try and shut down those conversations, they do appear elsewhere. So it's really important that we don't marginalise people within our system. So in terms of primary care development, I think it's fair to say that the goals that I've put up there, I don't think anyone would argue with the exception of 7-day working, which I think would raise some hackles in terms of whether we can or can't do it, whether we should or shouldn't do it. But I doubt very much that there's anything else on that list that wouldn't feel like an unaligned goal between a commissioning organisation, be it a CCG, or any other, and its practices. These are all things that we're all aiming for. I put porous boundaries as a way of describing seamless services, and I think we're all craving much more joined-up care, both in terms of being able to deliver it, but also being able to experience it. We're all patients of the NHS at some point, aren't we? So managing conflicts of interest, I'm forever surrounded by people who have anxious looks on their faces about conflicts of interest. And of course, we're going to these are inevitable, and they're going to be often difficult to manage. But I take the view that actually the most interesting people are the ones who have a conflict of interest, because that is actually much of a gripping conversation to have than having a conversation with someone who has no interest in what we're doing at all. So we can, again, run a mile away from these conflicts or handle them in a very sledgehammer approach, but it's really important that we try to take a considered view and a consistent approach to these. And certainly where conflicts of interest exist between a CCG and its member practices, it's really key that the relationship with NHS England, the area teams, is absolutely fantastic, because they are there to help us to manage those conflicts. And as long as we have a transparent process, and as long as we have those relationships that Johnny was referring to, we can't really go too far wrong. So thinking about another form of conflict of interest, if you like, it's the one in the consulting room. Clinical commissioning has really created a situation, I think, where GPs are genuinely faced by thoughts of commissioning, thoughts of managing the budget and the finances more effectively, but actually they're faced by patients day in, day out in their surgeries, and it is a genuine conflict of interest that we have created for them around trying to manage population health, if you like, and managing that patient's particular needs. And it's really important that CCGs manage this conflict as well as it manages others. We're not in the business of putting patients at risk along their sort of journey of care. So I've got a question to ask, a very simple one. This is certainly not up to the standard of a sociology GCSE, but it's really whether people in the audience feel that the development of general practice or primary care is actually really critical to the success of a CCG. And as I said, I have a particular view on this. And of course, A is yes and B is no. So I'll give you literally 10 seconds to answer that question. I've managed to count to 10 effectively, so we'll stop there. Do we have any responses? No? No one found a button to press? No? Well, we'll come back to that question. Perhaps you might want to reflect on whether general practice and primary care development is key and critical to CCG success. Oh, we've got a naught and a naught. So with that in mind, my second question was really whose responsibility is it? And again, I would suggest that we reflect on this widely, because, again, I think we're working in a permissive environment where, with a good relationship with your local area team at NHS England, we can actually make real progress in terms of developing primary care in a way that sort of suits everybody. And my final slide really was about making sure that we are not left with a legacy of practices and members who feel that they are outside a CCG, that actually we're working in an us and us situation and not a them and us situation. So thank you.